And here is your question. Right. So if you have read and understood, considering the critical care scenario, kindly tell me, how would you manage this patient?
I will manage this patient according to the ATLS protocol.
Okay.
As the patient came with the C-spine injury, I will put a collar, then and I will assess the patient at first by speaking. If he can speak, then I can secure her airway by giving oxygen. And if he cannot speak, then I will look and then feel and listen. And I will look for, is there anything that is there any facial injuries or not? Then I will feel his breath on my cheek and listen, is there any abnormal breath sound? Then I will manage airway by removing any foreign body, by fixing his face in trauma. Then I will do chin lift or jaw thrust. If the airway is not maintained, then I will go for oral or nasopharyngeal airway. If it
How
is
would
not
you
maintained,
reassure patient is taking adequate breathing?
I will mm,
First, you'll inspect, then,
yes, I will inspect.
and then.
Then I will listen, is there any abnormal breath sound or any then I will feel his breath. And after that I will assess,
You'll feel what?
is there
What
any
is the most important thing to palpate when you have to reassure breathing?
for breathing assessment, ma'am. I will look, is there any external chest injuries and
That you have
asymmetrical
done on
chest movement and
inspection.
respiratory rate.
That you have done on
Yes,
inspection. Then on palpation, you look for the trachea.
yes, I will look for the trachea.
All
And
right.
is there
Okay.
any surgical emphysema or not? And then I will
If there is,
parcus.
yes, if there is emphysema or something, then how would you manage? What would be your next step?
Then, ma'am, I will parcus. There, according to the parcus, then I will do needle thoracostomy in the fourth and fifth intercostal space by chest tube. Then chest, I will introduce chest tube,
All
and
right.
after the
This patient, okay, now goes in the shock. What would you do next? How would you reassure the next after A and B and then its circulation? How would you manage that?
yes. Then I will, after airway breathing management, I will assess her pulse rate,
Patient
blood
is in
pressure.
shock now. How would you manage it?
Okay, I will just um, stop any obvious source of bleeding. Then we'll open two large bore cannula and take blood and send for grouping, cross matching, and arrange for 4 units of blood. Then I will give him running crystalloid solutions and consider blood transfusions as soon as possible.
Okay, what are the 5 important factors that you have to consider when you're evaluating hemorrhagic shock or a patient with hemorrhagic shock?
Ma'am,
Yes.
heart rate, blood pressure, capillary refill time, urine output, and the conscious state of the patient.
Yes, good. And the loss of blood, amount of the
And
loss of
loss
the
of
blood.
blood,
Okay.
amount of loss of blood.
Then how would you monitor the response of this patient?
I will monitor the patient's blood pressure and urine output, and by seeing his conscious GCS score, and then
All right.
heart.
In this patient's history, you have read that patient had a primary survey and then the secondary survey. How do you define what are the differences, and why are they called primary survey, and why is it called the secondary survey?
Ma'am, primary survey we will have to go for airway, breathing, circulation, and disability and exposure. And the secondary survey where we will go for any definitive management. Like when the patient's conditions, like his primary parameters are stable, then we will go for the secondary survey. Like the
Okay.
secondary survey, we will go for definitive management, like fracture, rib,
All right. In this
fixation,
patient,
then
in
cervical
this
column.
case,
Yes, ma'am.
patient has multiple fractures. How would you decide which fracture to manage first?
Yes, ma'am.
How would you decide which fracture to manage first? Patient has multiple ribs fracture as well as the right clavicle fracture as well, and the right foot fracture as well. In exam, you're not going to get so many like description of the question. So how are you going to decide which fracture to manage first? Whereas patient has
I will,
severe neck pain as well.
yes, I will, first I will fix his, is there any fracture like limb fractures? I will fix that first.
Okay.
Then limb fracture, because in case of limb like femur fractures or tibia fractures or
Yes.
pelvic fractures, there is the loss of bleeding of more
What
than
are the
2 to
investigations that you'll ask for this patient?
I will do the cervical spine, uh, serial x-ray of the cervical spine, then chest x-ray, then pelvic x-ray.
Anything else?
Mm,
Any other investigation you'll ask for?
First, ma'am, focus assisted sonography of trauma.
Are they telling you? Don't read, just tell from your own.
Okay.
Yes.
Ma'am, CTs, at first, I will do the first to see the is there any collection of blood like perihepatic space or perisplenic space, pericardium, pelvis. And when I couldn't get anything, then I will go for CT scan.
Okay. What should be even more basic investigations that you should ask for before you'll go for the CT scan or then imaging? Full blood count. You have to know the glucose level, urea and electrolytes. Okay, how would you manage the fluid restriction in this patient, or fluid or nutritional status of the patient?
I will give his I will open 2 large bore cannula, then we'll give 1 liter of crystalloid, and at a time I will send blood for cross matching and grouping. When the patient isn't response, then I will go for dynamic fluid response.
How do you
Like
define dynamic fluid response?
like I will give the patient 500 ml of fluid. If the patient isn't response, then I will ma'am, actually I forget that.
That's all right. We'll discuss.
Okay,
Yes.
ma'am.
Thank you so much for tuning in. but yeah, it yesterday's was a lot more better. This one, like, you have to read it till ATLS.
Yes, yes, ma'am.
Anyone else want to tell? Anyone wants to help Dr. Inman recall the fluid status of nutritional support in ATL in RTA patients? No. And here is your question. Right, if you have read and understood, considering its surgical pathology station, can you please tell me what is the pathogenesis behind this patient's condition?
Stomach carcinoma is developed by a sequence of pathological changes. First,
Yes.
there is normal mucosa, and then there is chronic gastritis, which causes intestinal metaplasia, and then from metaplasia there is dysplasia, and then from dysplasia mucosal carcinoma develops, and from that there is invasive gastric carcinoma.
Good. Can you tell me what is the most common type of histological type of gastric carcinoma?
95% of the gastric carcinomas are adenocarcinoma.
Okay, good. Can you divide them into further?
There are two types of adenocarcinomas. One is diffuse type, and
Yes.
another is intestinal type.
Okay. What do you understand by the term diffuse type?
In diffuse type, there is a single cell which converts to a single cell in the mucous cells of the gastric glands, and they get proliferated, and then they get out of the crypts and invades into the lamina.
Okay, can you name few risk factors which are associated with gastric carcinoma?
Yes, ma'am. Risk factors associated with gastric carcinomas are Helicobacter pylori infection, atopic gastritis, chronic atopic gastritis. There is metaplasia, previous gastric surgery, FAP, and hereditary non-polyposis coli, low socioeconomic status, charismatitis.
Okay, good, thank you. Can you tell me how would you classify gastric carcinoma?
Madam, a Bowman classification system is used for classifying gastric carcinoma.
Yes.
It's four types: well circumscribed polypoid lesions, fang-eating polypoid lesions, ulcerated lesions, and lineages plastica.
Okay, right. Right. Okay. Can you please tell me what is virtuous node?
And virtuous, if in gastric carcinoma, and if it is spreaded by lymphatics, madam, the left subclavicular gland is enlarged. That node is called virtuous node.
Okay. Can you tell me what you understand by the term paraneoplastic conditions?
Madam, it's symptoms, signs and symptoms associated with carcinoma. When you have carcinoma, you get this sign and symptoms. In case of gastric carcinoma, you may get acanthosis nigricans or dermatomyositis. These are associated with gastric carcinoma.
Okay. Can you name few investigations which can be used in order to confirm? Yes.
Well, at first, I'll do the regular investigations like full blood count, urine electrolytes, and serum creatinine, etc. And then, madam, for specific investigations, I'll do upper GI endoscopy or double barrel contrast, barium solo contrast X-ray, and CT chest or abdomen.
All right. Okay. If you are asked to explain this report, patient's report, to the family members of the patient, how would you explain? What do you understand by the term signet cell carcinoma?
Signet cell carcinoma is one sort of adenocarcinoma, madam, which is rare and highly malignant, madam, and it produces mucin.
But how would you
And
convey this to the
Oh,
family
okay.
members?
All right, this is a cancer of the stomach, and we have it incompletely resected. So there is high possibility that the cancer will come back again, and it might need further surgery or chemotherapy.
What are the treatment options available for the patient with carcinoma of the stomach?
Madam, carcinoma, we can always do gastrectomy and esophageal, I guess. I don't know that.
Okay, can you explain or mention some complications associated with total
The complications
gastrectomy?
can be classified into according to
Yes.
their time, which is
Yes.
early and late. In early complications, there are anastomotic leakage, infections like pancreatitis, cholecystitis, and there might be hemorrhage as well. And in late complication, there is dumping syndrome and deficiencies of vitamin B12, and there might be bone disease, metabolic bone disease. And for gastric carcinoma, there might be difference as well.
Can you define the term dumping syndrome? What do you understand
Yeah.
by this word?
And dumping syndrome is that if we do gastrectomy operation, then the reservoir function of the stomach is lost. So, madam, there are sudden vagal symptoms like postural hypertension and tachycardia. These are explained. These are called dumping syndrome.
All right, you operated on this patient, and patient came back after 10 days and with a swollen or with the swollen arm. So what would you suspect?
And
Painful swollen arm, yes.
This might be axillary vein thrombosis.
Okay. What are the signs that will confirm?
And the thing,
Your
first of all,
diagnosis.
the patient has malignancy, so he's in hypercoagulable state. So, madam, and carcinoma of the stomach, which is signet cell carcinoma, it produces mucin that can interact with the platelets secretin and form microthrombi. And there is painful arm as well, so it might be axillary vein thrombosis.
Okay. Can you please tell me what you understand by the Crockenberry tumor?
Madam, if the gastric carcinoma spreads transceromic, then it and goes to the ovary, it's called Crockenberry tumor.
Can you comment on the prognosis of the patient after surgery or procedure?
Madam, after Crockenberry tumor, there's 5 years survival rate of only 10%.
Okay, good. Okay. Can you, are there any lifestyle changes that you can suggest to the patient?
Then the patient should avoid hot and spicy food and foods that contain nitrates. That they should be avoided.
Anything else?
And then the patient, if he drinks or if he smokes, he should stop drinking and smoking as well.
What is the mode of spread of carcinoma of the stomach?
Carcinoma can spread in different ways, such as, first of all, it may spread directly to the adjacent organs like pancreas. It may spread by lymphatic channel to the gastric, right and left gastric nodes, celiac nodes, or even hepatic nodes near to porta hepatis. And it may spread to the Burkitt's node by lymphatic as well. It may also spread transdermally, like in ovarian tumor.
Okay, if
And
this,
it may also
yes,
spread by blood, like
if
to the liver via protein.
Yes, patient comes back to you after 6 months and has deranged liver function test and has a lot of ascites. So what would you think?
The carcinoma has spread to the liver. He has conducted liver metastasis.
So what are the two pathological or what are the pathological tests you can suggest to the patient?
I'll draw the ascitic fluid and for cytology, and then we can take liver biopsy.
Yes,
we can also
liver
do
biopsy to see what?
To see liver metastasis.
Okay. Anything else? Any other test? Are there any
the
tumor markers that you?
Yes. CS72-4.
Okay. Anything else you might be interested in?
The FNAC of the supraclavicular might be done.
All right. Okay. Can you please tell me, like, about the classification of the stomach. How the carcinoma spreads on the basis of origin or on the basis of type,
I'm sorry.
like advanced and early and advanced, and how it
Oh, okay,
spreads.
okay.
Like it is confined
the
like
early-
TNM.
Oh,
What I wanted to know the classification, like TNM classification, if you can tell me. Or
the early carcinoma is confined to the mucosa, submucosa, and the advanced carcinoma is, madam, beyond the muscularis layer.
Yes.
That, madam, I don't understand.
And the macroscopically, they say it's of three
Three
types:
types, madam. It's ulcerating, nodular, or infiltrating.
fungating or infiltrating. Yes, very good. Okay, good. Time also has gone. All right. If you can please look at this picture and tell me what are you looking at. If you can just describe or discuss.
Now, this is
In
the
one or
histology of
Yes.
signet cell carcinoma, madam. There is vacuoles in the cells, large vacuoles, and the nucleus is to the periphery of the cell.
What is the stain which is used to
The
prepare the
HNO
slide?
stain.
Okay, good. Thank you. Yes, thank you. Very good. Here I've started your time, and here is your question. Right. If you have read and understood, considering it clinical examination station, kindly begin your examination.
Firstly, I will introduce myself, telling
Very
my
good.
name and my designation.
Yes.
Then I will confirm patient's identity,
Yes.
confirming the name and age of the patient.
Yes.
Then I'll take consent of the patient
Very
for
good.
the examination. I'll
Yes.
explain that I'm going to examine the shoulder area.
Yes.
In position, I'll explain that I would like to examine the patient in the standing position. And for that, I would like to have the exposure of shoulder area, neck area, and chest area, so that
Yes.
I can examine the shoulder properly. So after the consent taken, I would also explain the patient that I will examine the shoulder with looking at it, feeling for the shoulder, and moving and doing some special tests.
Very good. Yes.
Beginning with inspection, firstly, I'll inspect the patient standing position from front. And
Yes.
in inspection, I will look for swellings, redness, any scar, or any obvious deformity. I'll compare with the other side
Yes.
for levels of the shoulder, if there is any asymmetry between the two.
Yes.
And then
And
from the side,
front, side, and back. Yes. Yes. Continue.
yeah, from the side, again, I will look for swelling,
Yes.
contour of the deltoid region,
Very good.
and
Yes.
any scars, sinuses, redness. And from the behind, I'll again check for the symmetry of the shoulders,
Yes.
the same things as swelling, scars, sinuses,
Yes.
as well as redness. And then I'll look for the shoulder blade, scapula,
Yes.
if there is any winging of the scapula.
Yes.
And then I'll palpate, after telling the patient that I'm going to feel the shoulder, I'll palpate the shoulder,
What would be
looking
the
for the
position of the
temperature.
patient then?
In standing position from the
After-
front.
for palpation?
Yeah, for
Yes.
palpation
Can say-
from front. It could be in a sitting position also.
Yes. Yes.
So in palpation, I'll first palpate for the temperature
Yes.
and comparing on both the sides. After checking for the temperature, then I'll palpate the bony landmarks, starting from the
Tenderness.
midline.
Yes.
Yeah, for tenderness, starting from the midline for the, firstly, the acromioclavicular joint, and going lateral sternoclavicular joint, and then going laterally over the clavicle to the AC joint, that is acromioclavicular joint,
Yes.
then the acromion, and then greater tuberosity, bicep tendon, going posteriorly to the spine of the scapula,
Yes.
from medial to lateral, and then angle of scapula and medial margin, looking for any tenderness over that area. And after that,
Gradient between pulse.
palpation.
Okay.
Yeah, I'll check for the pulses also, distal pulses,
Yes. Next.
and could also ask for any change in feeling, that is numbness of the limb. Then I'll check for the movements of the shoulder.
Good.
For that, first I'll check for the forward flexion, and I'll either show how the patient should move in front. She should move the arm in forward direction towards head upwards, and that should be up to
I have
180
to
degrees.
break you down. Which movement would you ask the patient to perform first?
As I said, forward flexion. Firstly, it will be active. Firstly, it will be active.
Okay.
Yeah, firstly, it will be
Good.
active.
Yes.
That's why I'm asking the patient. So then shoulder abduction, starting
Yes.
from 0 and taking it on sideways up to overhead abduction, which is normally up to 170 to 180 degree. And I will show how to do the internal
And
rotation.
if the patient has impingement diagnosed already, what movement
Yes.
would she
Forward.
not be able to? Yes.
Forward flexion as well as abduction will be
Abduction.
painful,
Very good.
especially
Very good.
painful arc will be
Yes.
there.
Between
And
80
internal
to-
rotation.
Yes.
Yeah, from 80 to further
130 or
130
yes.
degree.
Yes.
They'll
Forward,
be
please.
painful.
Good.
So internal rotation, I'll show how to do. Basically, it's taking the palm to the back of
Yes.
the body. So
Yes.
that is how I'll check the internal rotation, which will be checking for the infraspinatus. And then I'll check for external, subscapularis. And then I'll check for external rotation in 90 degree flexion of the elbows, with the elbow tucked to the sides of the body and taking both sides outwards.
Good.
So that's how I'll check for the infraspinatus and teres minor. These are the movements, active movements. I'll check for any pain in these movements or tenderness, or
And you'll feel for the
pain.
crepitus as well.
Then I'll palpate for the crepitus, and then I'll do the special test for the impingement. First is the Neer's impingement sign, which is the
Very good.
forward flexion.
Yes.
Active forward flexion will be painful.
Yes.
Then I'll do the empty can sign, in which
Yes.
I'll ask the patient to abduct the shoulders and flex 15 degrees the elbows forward, and arm rotated inwards with thumb pointing downward. I'll ask the patient to move the shoulders up while I'll be giving resistance downwards. If that will be painful, it will show the supraspinatus tenderness.
Very good.
And then resisted external rotation. Again, in the external rotation position, I'll ask the patient to move the shoulders outwards and resist it with my hands. If it will be painful, then it will be tenderness of the infraspinatus or impingement. Then shoulder, the lift off test, which is called Burgess lift off test. In the
Yes.
internal rotation position, I'll try to hold the palm of the hand of the patient to the back while asking the patient to lift it off. If the patient is unable to do that, then there'll be weakness of the
present
subscapularis.
Your case now.
Yeah. So in order to complete my examination, I'll do the examination of the cervical spine and elbow, as well as distal peripheral neurovascular examination also. This is a 23-year-old female with pain mainly in forward flexion and abduction. So these tests are positive. My main diagnosis is shoulder impingement due to supraspinatus tendinitis.
Okay. How do you plan to manage this patient?
So in supraspinatus tendinitis, firstly, the main management is conservative with the painkillers, NSAIDs. Initially starting with paracetamol. If that does not work, then we can upgrade the pain management with aceclofenac and other NSAIDs. And then physiotherapy as well as hot fomentation can help. In case all these gets failed, then I could go for surgical treatment or ultrasonic treatment of the supraspinatus tendinitis. If it fails, then surgical management of the supraspinatus tear, if it is there, or retraction is there, then we have to repair that. And
Alright.
as in the
Yes.
stem, it's given that the shoulder is lax and mobile. So it could be a ligamentous laxity also. We have to
Yes.
diagnose that with the MRI, and
Yes.
X-rays will be important.
If this
and so
patient
if
would
there is,
ask you, because she has a tournament in 2 weeks, if she asks you to take part in the tournament, what your advice would be to her?
so initially we have to diagnose the exact problem. For that, we will have to go for further investigation, X-rays and MRI. And if there is a major problem in that, which includes ligamentous problem or tear of the ligaments, then she can't participate. We have to tackle that first.
How long? For how long? She would not be
So,
able to? What
so if
rehabilitation
it's
advice would you give her? In other words,
so if it's not torn, it's basically tendinitis, then we'll have to wait for at least 6 weeks for with medical management. But if it's surgical, then even after surgery, we have to go for physiotherapy. So 3 to 6 months, she could not participate,
okay,
and depends on rehabilitation.
yeah, 6 months approximately. Okay, and one last question, please. Why impingement is common in this among the swimmers?
Okay, so repetitive movements of the shoulder while swimming,
Yes.
it causes wear and tear, and
Yes.
the tendons get stretched up, which causes inflammation in the subacromial space, and which further leads to impingement of the tendon.
Excellent. Good. Thank you.